I was in the ER yesterday.
Hey guys, ready to knock it out?
Yeah.
Get out of here. Cool. All right. So a lot of these subject matters, remember we just talked about hearing impaired patients, visually impaired patients, all of that stuff. So I'm not going to spend a ton of time with that, but there is some new subject matter, some new considerations. If you have patients with some of these ailments, that definitely are going to go into a lot of communication and treatment as well. Thank you. All right, so guys, we've got two types of disabilities that we really kind of categorize both of these things in. All right, we have a developmental, sometimes most of the time that's going to be a physical restriction, and an intellectual or cognitive, that's going to be the bandwidth of the function of the patient's brain and ability to carry out all of those different kind of messages is going to be hindered. All right. Sometimes you will see just one, sometimes you will see both in the same patient presentation. So again, we've got physical and we've got cognitive that can factor into communication and or treatment. Different things can cause this. It can be something that's genetic, just in the DNA, the patient's born with it. It can be an injury or a sickness that causes the disability, physical or cognitive. Typically, guys, that's going to be sometimes malnutrition can cause it, sometimes poisoning, but it's typically it's going to be congenital or it's going to be sustained by illness or injury. Okay. Just like we talked about with the different psych, the different issues, there is a spectrum. You can have patients who have these diagnoses or these impairments that are highly functional. They're only slightly impaired by it, or we can have someone who's significantly to the point where they can't conduct like daily activities, physical or intellectual. So we're going to see a very broad spectrum when it comes to all of these things that we're talking about. Again, guys, who do we approach first? Patient. All right. If for whatever reason, cognitively or physically, they're not able to respond, then we take a step back and then we go to a caregiver, family member, something like that. Okay. Because again, just like with these geriatric patients, not every geriatric patient has dementia and has hearing and visual problems, right? If we bypass that patient that's sitting right there in front of us and go talk to somebody else and they're totally cognitive aware and they're like, hi, guess what? I'm the patient, not that person. It can become across very offensive. So just make sure we approach the patient first and then adjust the communication accordingly. All right. First thing we're going to talk about is going to be autism. All right. Anybody know anyone personally with autism, experience with that? Okay. What are some characteristics or what are some presentations of autism? Okay, so some do not appreciate physical contact.
A lot of them can't make sense of like social situations.
Okay, so there's a lot of social norms or social boundaries that are not easily picked up and interpreted by patients with autism.
My buddy does not understand sarcasm, and that's the only language I speak.
Okay, that would be unfortunate. Yeah. All right, what else?
I have a niece who is has hyper auditory sensitivity. She has to wear those little noise canceling headphones.
Yeah, so depending on where on that scale of being impaired, they can be very sensitive and react very negatively to loud sounds, bright lights. All right, what's an ambulance do?
Sirens and lights.
All right, there was an autistic patient that we used to respond to a lot. It was a 16-year-old. He would have some violent outbursts. And they called so often. When the mom called into dispatch, she would tell dispatch, hey, will you tell the crew if it came out as an emergency triage, like when they turn on this X street, turn off the lights and the sirens, please, because it did nothing but, amplify that patient's behavior. Guys, sometimes they have very repetitive kind of tics, if you will, physical. Sometimes they repeat things over and over again. Sometimes they are just so wrapped up into what their brain is focusing on, they're not really aware of other people around them. Sometimes it gets to the point where they're so severely impacted that they're nonverbal. They don't speak. Okay. Again, there are very highly functioning autistic people, and then there are people who are significantly impaired to the point where they have to have somebody help with daily activities and daily, life with them. So what do you think is going to be the best way to approach these patients? Okay, so be mindful. Again, we're going to pick up some body language. If we can see that they're having these repetitive motions, or they might be kind of pacing or in like an excited state, okay, be mindful of that. We probably don't need to go right up to that patient and be like, hey, pal, what's going on, right? Touch their shoulder. All right, so be mindful of their body language. What else? Mindful of your body language. How might we need to move? Slowly, calmly, right? We don't want to get excited to hype up their excitement as well, or their fear, or their anger, whatever they might be experiencing. Again, we do this with every single patient. Introduce yourself. Say, I'm Kayla. I'm a paramedic from Grady. I'm here to help. What's going on? What can I help you with? Let them know what you're doing before you do it. All right. What else might we need to rely on when communicating with these patients? Yeah, guys, they have a person. If they are significantly affected by this autism, they have a person that is their comfort blanket. If that person is not around, the entire world is turned upside down. That person can typically effectively communicate with the patient and effectively communicate to the crew what that patient's trying to relay. So if that person is around, we absolutely want to rely on their communication skills, their comfort, their presence, all that stuff. Okay. Just be mindful. Sometimes if we are having to like physically interact with these patients, they might become combative. Don't take that personally, right? Don't haul off and just like punch them back. Keep in mind too, like those dementia patients, Alzheimer's patients can become violent. Do you want to haul off and hit an 80-year-old grandma just because she tried to swat at you? No. But just keep in mind the reason that they're having these emotions and these outbursts. Okay. Guys, typically diagnosed by age 3. You hear all these PSAs that have come out. If your baby's not smiling by age 6 months, they might have autism. All right, that's why these milestones are not concrete, set in stone. All right, maybe if by the age of 3 we're not having any type of social interaction, we're not speaking any type of noises or words, we might start thinking, okay, we're a little far past that point. Let's try to explore and see what could possibly be going on. Doesn't mean that the child is autistic. Okay, so just keep that in mind. This is a newer thing. Not that it didn't exist before these past couple of years, but it's just been more explored and more exposed. All right, so it's very possible you might have an older patient that displays these characteristics but does not have a diagnosis of autism. All right, so either they're officially diagnosed or they're not officially diagnosed. We're still going to treat and interact with these patients the same way. Fair enough? Anyone that knows the people who have autism, did I miss anything like significant? Okay. All right, Down syndrome. What is Down syndrome? All right, genetic chromosomal defects. Okay, this is congenital. All right, this is also something if mom is receiving prenatal care and getting these ultrasounds, it will be known that the child is going to have Down syndrome before the child's born. Okay. There are some physical attributes to the patients who have Down syndrome that could cause some medical problems. So that's always good to know if mom knows before baby is born. They say studies are linking if mom is significantly older when she has the child, like I think they targeted at over the age of 35 or 40. The child's more predisposed to having Down syndrome, and it also is a genetic thing, so it can be passed down generation to generation. Okay, I put this here because it makes me so happy. This little boy, I think his name's Owen Gerber, or no, it wasn't Gerber. It was Oshkosh, Bagosh. All right, it's a very popular, successful clothing company for kids, and they actually made him like one of their models, and it just made me happy that he's just so cute. And now he's a model. They do have distinct physical appearances. Again, guys, there is a spectrum. You can have someone who is very slightly affected by Downs or very significantly affected by Downs. The physical attributes, for the most part, are going to be present anywhere on that scale. Okay, their heads are a lot larger. Okay, they have a very, very large tongue, and their eyes are more slanted and they're set closer together. That's typically the most significant physical attribute, or the eyes, the way that the eyes present. Okay, so what do you think that big tongue is going to cause problems with? Airway, right? Aspiration, occluding the airway. So keep that in mind. Big tongue, big head, probably not the best combination for keeping that airway open, especially if there's significant altered mental status or an unconscious unresponsive state. So it might be that even if this patient's not a pediatric patient, try the sniffing position. All right, make sure we're fully aligning that airway, we're opening up and it's not kinked off because of the large head or the large tongue size. Asher. I knew it was something, 2 syllables. But yeah, oh, he's so cute. Because of some anatomy differences, they are more predisposed to some medical problems, especially cardiac related. Hearing and visual problems are also commonly associated with significantly affected Downs patients. You don't have to worry about intubation just yet, but it is challenging because of the different anatomy. They're more prone to seizures. All right, how do we manage that? Like any other patient, prevent further damage to the head, be vigorous with the suction and airway management when they go postictal. Okay, it doesn't change management. Some of the joints are a lot different in structure, so it makes them more predisposed to dislocations or trauma. How do we treat a dislocated joint? Immobilize it, right? Again, interact with these patients, approach them first. Guys, when I worked in the ICU, there was a highly functional person who worked as a pharmacy tech at AMC. I mean, totally functional, lived by himself, came in, did his job, got paid. So just because they have that diagnosis doesn't mean that they should have that stigma around their ability to do things or to communicate. Approach your patient first and then change it up if we're not getting appropriate feedback. Downs patients will typically have a person as well. So if that person is around, is that sense of comfort, help communicate, help ease the cooperation for that patient, absolutely utilize that. All right, do we need to talk about patients who are visually impaired again? Different ways to interact with them, different things to consider for patient care.
Can you one more time for me, please?
For visual?
Yes, ma'am.
So just be very mindful that we need to, not that we wouldn't with every other patient, introduce yourselves, give a verbal cue that you're on scene. When you're moving around the patient, let them know where you're going to feel me touching you. Hey, you're about to feel this sensation. You know, we're about to lift you up. You're going to feel a couple bumps, because not having that sight makes them very vulnerable, right? We don't want to like take anything or take them by surprise when it comes to just a daily motion that we use to interact or to assess these patients. Just make sure you're explaining, hey, you're going to feel me touching here. If they have a seeing eye dog or service animal, do they come with us? Yeah. If at all possible. Same guys with the autistic patients and with Downs patients. If they have a service animal, we will transport them.
Do they ever have problems with the service animals where like the dog won't eat near the patient? The patients?
No, if they're a legit trained service animal, they go through literally years of training. They have to be well mannered. They have to have a very kind of like docile personality to like make the cut. It's like doggy boot camp for service animals. So, but yeah, just make sure that you're saying everything that you're about to do before you touch these patients. If they have a cane or a walker or anything like that, we want to take it with them. Make sure that they will have that if they get discharged or if they're having to move around in the hospital type thing. Hearing impaired patients. Do I need to go over the big stuff for that? Guys, there are some simple that we did a really cool class on one of the conferences that we went to a couple years ago. It was sign language for patient care providers. So just if you, I don't know if they still teach it in school, but like I know the alphabet, they taught that in school. They taught like simple like words in school. But it's a really cool kind of side talent or knowledge to have. So they can possibly be fluent in ASL, American Sign Language. So if you just know these simple, some of the simple signs, it would be helpful. If not, you can just do your best to play charades, right? Or if not, you can write it down, put it on pen and paper.
I got a transcription app on my phone from Google that just writes out everything you say, as you said. I did find it's a little hard to use with a mask because your voice being mumbled kind of messes with the dictation.
I literally watched this yesterday. They just, I don't know if they tweaked that app, but they made a new app for healthcare providers who are talking through a mask. It like picks it up a little bit more sensitive, so you can.
Probably made a new one because they have to be with a lot of analytics stuff to be compatible with it.
Yeah. So, but they literally just are. It's being put on all the 911 pages and the EMS pages that for the patients who are already hard of hearing, having that muffled, tone, you can just hold it there and you talk, and it literally it faces the patient, and it just everything pops up what you're saying.
Go check that out.
Yeah. So there's the sign language alphabet.
Is it pretty common, do you find, that you need to use sign language?
Not always.
Would it
No.
be beneficial to go to a class? I mean,
It's
sign language
cool.
is
I
always
think it's
beneficial.
a cool, knowledge to have one under your belt anyway. But I would if you have the time.
I mean, I agree with you.
My mom knows sign language when my dad's tired of us fighting, we just fight in sign language.
Yeah, guys, I would highly encourage, if you're probably not gonna use it every day, the sign language, but they have sign language for medical or healthcare providers and like condensed languages for medical providers. It's not like you have to be fluent in the entire language, but just the simple like allergies, medications, pain, all of that stuff, hospital, all of that, it has it condensed in different languages. So if you have a language barrier, you do your best to communicate. Again, guys, hearing aids, they come in all different shapes and makes and models.
They're smaller than that now. My dad has minor hearing loss and his isn't even visible if he's wearing one.
Yeah. So they can also, I always forget to put this picture in, a cochlear implant. All right, it is a circular device that's actually implanted into the bone here. And it is those cochlear, the little snail-looking bones that help you perceive sound. If those are not functioning, they can actually do a transplant and put an implant in there. So if you see something that's adhered to the skull, then that means that they have had that transplant or that implant. Okay. Don't try to mess with these hearing aids. You might break it, you might make it worse. I don't know, unless you have personal experience with them. I would just leave them be and say you can take it with us, or do you know how to replace the battery or something like that. All right, cerebral palsy. What is this? What does it affect? Affects the body, but how? Okay, so but what does it stem from? The brain. right? It's a neuro issue. Whether they were significantly hypoxic when they were inside of mom, in the process of coming outside of mom, it can be caused by a TBI, or it can be caused by significant meningitis. All right. So if that brain is negatively affected by hypoxia or injury or illness, then you can develop cerebral palsy. How do these patients present? Again, there's a scale: mild, severe. You might know anyone with cerebral palsy?
I do.
Okay. So how do they present? Okay, so yeah, that muscular coordination, that fine motor coordination, even just the ability to walk is usually typically affected. Okay, a lot of these patients have either wheelchairs or they have some type of device that assists their movements. Anybody watch Breaking Bad? Walt Jr. He had cerebral palsy. The actor that plays him, real life, has cerebral palsy. So he always walked with like the arm canes. Okay, so highly functional, but you can have patients who are wheelchair bound. It can affect the ability to speak. What do you think these patients are more prone to because it's dealing with the brain? Seizures. Okay, so they are more prone to seizures because it is a neurological condition. So be aware, anticipate that if it happens. How do we treat it? Any other patient?
The girl I know with palsy, I think that was in her first homework assignment. She was very spastic. She was wheelchair bound. She couldn't stop moving.
Yeah.
It made getting vitals very difficult. I couldn't get a respiration right. So that is something that you may or may not have to deal with depending on the level of their condition.
Yeah, because guys, cerebral palsy, autistic patients, patients with Downs, what if they're not cooperating to get vital signs?
Yeah.
Do what you can, right? Unless that patient looks critically sick, I'm probably not going to press it, right? If they look like they're perfusing, if they have their baseline mental status and they don't let me get anywhere near them, they don't let that, their person help with that interaction and that treatment, how do you document that?
They perfuse vital collection or something.
Okay, so, and not to paint it in a negative light, but you would probably just say, due to uncooperative patient, unable to obtain vital signs. Okay, so just don't create an issue for maybe like a violent outburst or something like that based on something that, if they're not blue and they're perfusing and they're not pale, cool, clammy, am I super concerned? No, don't make an issue that if it's not already, present. All right, guys, anyone who has these physical disabilities who are bound to a wheelchair or in bed, what are some things we need to consider about that? So these patients who are bed bound or bound to a wheelchair, what are some things that I need to take into consideration about moving them or physically? Okay, so maybe an emboli, yeah. Sores. Okay, so we see significant atrophy, which can lead to what? So if you ever go to like a nursing home, okay, yeah, so they're going to be very weak because they actually develop what we call contractures. So if you have a patient who is, unable to control, let's say from waist down, whether it's paralysis, cerebral palsy, whatever that is, if they're constantly sitting in this position, right, we're not using those muscles, what's eventually going to happen to their range of motion? It's not going to go far past this. That's why a lot of times you see like physical therapy in the hospitals, even in nursing homes, they'll literally like take the leg and they'll straighten it out and they'll move all the muscles around and they'll make sure that it doesn't like get fixated in that one position. Sometimes we have patients who have severe contractures. What do we need to keep in mind about this? Do we need to try to do we need to try to pull it and straighten out? No, we can cause significant pain and trauma. All right, so if it's to the point, guys, we can give it a little bit of a pull and see if we meet resistance, to see if we can just kind of coax that limb to go where we need it to go. But if we meet resistance, or if the patient is saying, or, communicating that hurts, we are going to put the stretcher straps on them as we find them. We're just going to have to work around that contracture. Okay. Make sure they should have like a lot of pillows that you can prop up underneath, just like keep these limbs propped up, but do not try to straighten out contractures. And that happens a lot with people who are bedbound or have very small control of their muscles or their body. Take walkers and wheelchairs with you if you can. Guys, the big, like the Rascal, the wheelchairs and motorized ones that they like glorify on the. You guys ever seen those commercials for them? They're like, oh, I'm going over the Hoover Dam with my Rascal. Like, I guess it's because when I was home with my kids, it was like midday, like Price is Right. And you're like, yeah, these old people are home at this time, so we're going to advertise these scooters. Those aren't going to fit in the back of the truck, and they're extremely heavy. So if this is the case, if the patient is absolutely dependent on that wheelchair, call supervision and say, hey, we need to arrange a wheelchair van, whatever, to come pick this up and take it to the hospital because we can't fit it in the back of the truck. Make sure that we're trying to get that to the patient because they're literally, they can't do anything about it, right? Another thing that they don't talk about is Bell's palsy. What's Bell's palsy?
So unhappy your face goes.
So it's typically more so the face, but it is a temporary spasm or loss of control of sometimes one side of your body, but a lot of the times it's targeted to the face.
So it goes away.
Yes. Well, not exactly goes away, but it's like you can make it not be as bad. All right, one of my really good friends in high school, she had Bell's palsy. All right, she always had like a little slant to her eye, and you could tell when she smiled that this part didn't go up as high as the other. Whenever she was really tired or really stressed or not like taking care of herself, it got significantly worse. It was much more obvious. All right.
Yeah, the giant from Game of Thrones.
Mm-hmm.
As well.
I think so. So,
Constraints of the face or something.
so inability to effectively control the facial muscles. What does that sound like?
Stroke.
Facial droop for stroke. All right, so understand Bell's palsy is a thing people can have baseline. So again, we don't want to confuse that and freak out. Oh my God, you're having a stroke. All right, if we do see that facial droop and nothing else is really adding up or matching, these stroke symptoms, we can say, hey, does your face always look like this? Do you have a history of Bell's palsy? Because we don't want to be that crew that sounds the alarm for a stroke alert and we roll in and they're like, dude, this happens all the time. Okay, so just recognize Bell's palsy, know what it is and what it can mimic. All right, so spina bifida, guys, we touched about this a little bit yesterday. Again, this is discovered in utero. If mom's getting ultrasound, she's going to know this is going to be happening with her baby. The spinal cord is not totally fused. It's not exposed to the outside. So what do you think we're going to have some issues with?
Spinal injury.
Yeah. All right. So the ability to control, extremities, those bodily functions. This is pretty much the medical version of having a spinal cord fracture. All right. Over several surgeries, they can kind of mend everything, put it back to where it needs to be, but sometimes these patients have lifelong side effects from this birth defect.
So somebody who has that, how often do they walk?
Fairly often, because if you fix it early on and give the everything time to like regenerate and get back to normal and start training it to function at an early age. All right, so guys, paralysis, for whatever reason this happens, if it's an injury, if it's an illness, if it is just something that stems from a congenital issue, what are some things that we can see? Inability to control extremities, all right? If it's higher up in the spinal cord, what do we typically see? Okay, so typically if it's a higher spinal cord injury or illness or issue, we see all four extremities are affected, right? If it's a lower issue or injury, typically it's like, the lower extremities are affected. But yeah, if it's a very high spinal cord injury, we lose the ability to control that diaphragm, those vital functions, the ability to speak, all of that stuff. So it just depends where in that column are going to be like how significant or how impactful those side effects are. Because these patients do have the inability to control these natural, normal bodily functions, we might see some additional equipment that goes along with these patients. All right, what's a catheter? Urinary catheter? Okay, so it's indwelling in the urethra. It will collect urine as it's produced, so the patient's not having to worry about, like getting up and going to the bathroom or, urinating themselves. It's just constantly collected. Right, they also do make fecal bags in that manner too. So that's something you might run into. But typically they'll move away from the rectal tube and go to like a colostomy bag. What's a colostomy bag? Okay, so typically they kind of like go straight to the intestinal tract, the digestive tract, and say, hey, I'm going to collect the fecal waste here instead of having it transported through the rest of the colon and all that stuff and getting rid of that solid waste like you normally would. All right, so that's something that can cause a source for infection. It is not fun when they come loose or they're leaking or they run out of bags. All right, because it's an open stoma. It doesn't just like close shut. It will stay open and will have drainage consistently. And guys, it's not going to be totally solid drainage. All right, I had another student be like, there's going to be like lots of turds that come out of there. No, they modify their diets. The intestinal tract adapts, and it's typically more of a liquid version, but it's going to be fecal matter nonetheless. So feeding tubes, trach tubes. Again, these two might cause some issues for aspiration. Remember, you're dope pneumonic when it comes to trachs. They might have some respiratory distress because the tracheostomy itself is dislodged or obstructed or all that stuff.
Luckily, not some big patients now on their trach. Yeah, because stuff falls out of it. It's
Makes
not fun.
sense. Yeah.
It's not something you think about.
No. Guys, if the patient is cognitively aware, but they just have that physical ability, be like, hey, dude, what's the best way to do this? Like, get them involved in moving them, or, if they're cognitively sound, talk to them. Don't just ignore the fact that just because they might not be able to walk doesn't mean they can't hold a conversation with you or tell you how to better their care. Bariatric patients. All right, guys, we talked about this with the therapeutic communication. Okay, what are some things we need to keep in mind with bariatric patients?
Our own safety.
Your own safety in what regard? Okay, knowing your physical limit. If you and your partner cannot safely and feasibly lift that patient, we need to do what? Call for a lift assist. If they come. I don't know if they will, but what else do we need to keep in mind with these patients? Okay, be very tactful. All right. Trust me, it is very easy to just want to just pop off at a patient when you're busting your back or you're exerting yourself physically and they're not either grateful or they're just being a jerk about it. But make sure you're professional. Make sure you're tactful. Try not to use a lot of slang terms when it comes to bariatric patients. Be mindful that your voice carries. Okay, so just be professional, be tactful when it comes to the actual interaction. How do we want to best phrase, yo dude, you're too fat, I can't lift you, I gotta wait for somebody else to come help me. Is that wise? For your safety and our safety, we can't lift you alone. So we're gonna need some additional resources so, everyone comes out of this uninjured. Right? Because I mean, if you're on that level with your patient, you're gonna know if you can like talk real to your patient, right? Like, dude, do you want me to drop you? Like, that's not gonna be fun. Like, I don't want to hurt my back. We'll hang out. Somebody else will come here. We'll get you to the hospital. Right? But for safety reasons, we're gonna need some additional resources. Remember that you might need additional equipment, like literally a bigger stretcher. You might need not the whale tarp, the mega mover. Okay, so just keep these things in mind. One size fits all for these backboards. So just keep in mind your actual available equipment. Try to get them involved as much as possible. Hey, can you grab this? Hey, can you try to pull yourself up? Get them to try to cooperate in any capacity. Bariatric patients. Do we really want to lay them supine? Why? Okay, so remember when we talked about obstetric patients, supine hypotensive syndrome, weight of baby, all that fluid pushes up. Okay, so same with bariatric patients, just the weight of their actual body can make it very hard to breathe. All right, most of the time they're not going to be comfortable. They'll tell you, hey, no, I want to sit up. But we do need to try to place these patients in at least like a semi-Fowler's, if not like 90-degree angle, depending on what's going on with the patient. So we can impact their respiratory effort if we lay them flat. Just keep that in mind. Probably if you are having to do get additional equipment on your end, you probably just want to over the radio say, hey, be advised, this is a bariatric patient. Okay, do we want to call them fat? Do we want to call them Shamu? Do we want to call them even overweight? Bringing you a big one? No. All right. But what does the hospital need to prepare for? Their bariatric equipment. Okay, so just a simple, when you're wrapping up that report, be advised, patient is bariatric. Or, you might want to, probably going to need a bariatric stretcher, just so they can already have that on hand and the patient's not having to sit there uncomfortably while they go get it, all that stuff. Awkward, this is awkward. All right, so again, guys, remember we talked about this in the respiratory chapter, ththese tracheostomies. Where does their airway start? Right here, at the opening of this tube. All right, so if we have to bag a patient with a trach, how do we do that? Do we do it up here? All right, so remember, any oxygen delivery, any airway management does not start up here at this upper airway. It doesn't go from point A to point B, okay? If we're giving oxygen via non-rebreather, we're gonna put that mask directly on the opening of the trach. If you're bagging, we're gonna take the face mask off and hook it up to that stoma right there and bag there. Okay, don't be that crew who rolls into the ER with a non-rebreather mask on your patient's face that has a trach, because where is it going? Okay. So again, that dope mnemonic, you should know it. I think that was a pop quiz for you guys, right? Patients with trachs are often on vents. Do you think we can transport this in the back of the truck?
No.
No. There are portable ventilators. Most of the time, they're about the size of like an AED. Guys, if you have somebody, if your patient is not coherent, if there's somebody from that facility that offers to say, hey, I'll come in with you, that knows how to work the functions of that portable ventilator, that is great. Bring it on. Come on with me. If we don't have anyone, are we trained to use these?
No.
No. Okay. So yeah, just DC them from the trach and you are now becoming the ventilator, right? You're just going to manually bag them the entire duration to the hospital. Okay. So that means you're going to be solely dedicated to what? Bag. You might want to bring maybe some additional resources just so you can have an extra set of hands. But you will become the ventilator if we don't have anyone who volunteers to say, hey, I'll come with you. Most of the time you don't. So just back them the whole way. Apnea monitors, we talked about this, right? What are these?
It's when it's like adults or something you put on a child, right? And then when they breathe, when the breathing is.
Yeah, so typically we see these in infants, all right, because sometimes if they have these apneic episodes where they stop breathing while they sleep, we try to monitor it, try to prevent that SIDS, right? This is it's called an owlet. They used to be only you could get them if the doctor prescribed them to you, but now you can order stuff like this online. All right, this was my paramedic mom splurge with my first kid. It's a little pulse ox. It goes on a sock around their foot. This sits on your nightstand. There's an app on your phone. You can actively track their heart rate and their pulse ox. If it goes below a certain number, the pulse ox and or the heart rate, this thing gives a very loud alarm. You keep it on your nightstand so that alarm wakes you up. Oh crap, these numbers aren't good. You go check on the kid, and versus you don't know that it happens in the middle of the night and they don't wake up type thing. So you might see that. It might be a little belt. Typically they're moving towards like a smaller attachment so the baby can actually sleep comfortably. So that's another model you might see. What's a pacemaker?
Basement for your SA.
All right, so it's a cardiac issue. The patient's having some cardiac issues. Your what node? Your SA node is not working, right? It's having some issues. It's got some hiccups. That is the heart's natural pacemaker. So that SA node is either not firing or it's misfiring. So there's a pacemaker that is implanted to stimulate, okay, heartbeat, beat, beat. If that SA node kind of craps out, the pacemaker's like, nope, 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 beat. All right, so we can infer what if a patient has a pacemaker? He has cardiac problems, okay? We can also infer what if our patient's altered or is unconscious. Pacemaker could fail. It could be, we could be having some really bad like heart dysrhythmias, or we could be having some really bad bradycardia because maybe this pacemaker is not working.
Will those devices have like an indicator if they're working correctly, or?
I don't know. I don't
I mean,
think so. Yeah,
obviously
the
the
patient's
has an
like
indicator, but
perfusing. I don't know. I don't think there's an alarm or anything that sounds. I might be mistaken, but I'm not sure.
In general, probably not. Self-diagnostics are not super common like this.
What does it look like? A little raised, right? It's either going to be here or here, depending on the cardiac surgeon's preference. But it's about, they've got them to about yay big now. They're rather small. If there's not significant adipose tissue here, we'll be able to see it. It'll be firm to the touch. If we see that patient's unconscious, unresponsive, okay, what do we probably need to do?
Don't put the AED pad there.
Don't put the AD pad there, but what do we probably need to do? After we confirm they have a pulse. Huh?
Confirm that they have.
They have a pulse, they're not in cardiac arrest. What do we probably want to do? Your patient's alive, they're unconscious, they're altered, but they have a pulse, they're not in cardiac arrest. What do we probably want to do? Okay, we're managing airway, we're managing all of that. What else?
sure.
You would say get a 12 lead. They have a pacemaker because they have cardiac problems. Let's get a 12 lead. Right? There we go. All right, guys, what's an LVAD?
Basically just
Left ventricular assist device. All right, guys, this is for patients who are on the list for a heart transplant. Who is not working? Left ventricle. All right, so what are going to be specific about these patients? No pulse, right? Because the heart, the way that we perfuse, the heart rhythmically contracts. All right, when it comes to that LVAD system, it's just a constant movement, a constant pour, a constant pushing of that blood. So if you're real quiet and real still, you might feel like a subtle like vibration of the movement, but you're not going to feel a palpable pulse because that's not what's happening anymore. Right? How do we manage these patients?
Very carefully.
Very carefully. Hope that they are what?
Their own expert.
Hope that they're conscious and that they can tell, because guys, again, this is a last resort before you get a heart transplant. They go through weeks and months of training and education on the equipment, on all of the stuff. So if your patient is conscious and alert, they let them run that call. They're going to say, okay, they're supposed to give you a card and say, hey, call this doctor, take me to this place, blah, blah, blah. The only LVAD patient I ever ran, it was just a malfunction like with the battery. But she was awake. She goes, all right, honey, let's go. We won't be going up to St. Joe's. And she gave me the card. She goes, call Dr. So-and-so. And no, don't do this or don't do that. And I'm like, yes, ma'am, whatever you say. All right, so hopefully they're conscious. Do we do compressions on LVAD patients?
No.
Yeah, that's not there.
AHA recently changed their recommendations to yes, we do compressions on LVAD patients if they're in cardiac arrest. All right, so
Is that device, like,
what?
where is that? Like, is it?
So it's some inner tubing connected here to the heart, but typically it just comes out as like just a little pack pump that they wear.
Okay.
So
So the wire like goes
Coloscopy, right?
down.
Not like a pacemaker, you compress, you just like,
Well, no, but I mean, you're effectively like tearing it out of the heart when you're doing compressions, right? That's why they used to say don't do compressions on LVAD patients because you're really cold heart. But I guess AHA said it's better than nothing.
I mean, I guess you can't make them more dead if they're in cardiac arrest.
Ain't getting any better.
if an LVAD, if a patient with an LVAD presents and you can't feel a pulse because of that LVAD, like should we assume?
So what are some other signs that you might notice if your patient doesn't have a pulse or circulation?
Wait,
Sign on.
CRT.
So we could maybe look at CRT, we could look at the skin color, condition, temperature. Yeah, because I mean, technically you can try to listen to heart tones and you can hear it's like a whir. It's just like it's a weird vibration.
Just
Yeah, it's just a continuous flow. It's not a rhythmic pumping. All right, an external defibrillator vest. What is this? It's a defibrillator on the outside because remember we can have those implanted defibrillators if we have a patient who consistently has some heart issues. They're consistently going into like a V-tach rhythm or a cardiac dysrhythmia. It will internally, it's like an implanted AED. It recognizes that we're going into that rhythm and it will internally shock it back into hopefully a normal rhythm. This is like a little vest they wear on the outside and it's pretty much like a constant AED on them. This will alarm when it's about to shock because this can transfer to you if you're touching the patient when it shocks. The internal defibrillators will not shock you if you're touching the patient, it goes off. These are very uncommon. Typically, you'll see these on patients who are not healthy enough to undergo that implantation surgery for a defibrillator, but we really don't see a ton of these. So a central line is what they call this, a central venous catheter. What is this?
Taking frequent meds.
It's like an indwelling IV. So technically an IV is indwelling, it stays inside your vein until they take it out. But this is here for months and months and months. All right, so people who get chemo, people who are constantly getting transfusions or different medications to avoid consistently puncturing the veins to give this medication or this treatment. This just kind of hangs out and they just access these little catheter tips and they just go ahead and hook it up to the meds when the treatment's there. All right. Do you guys touch these? No. They just changed it to where we can access these and push meds through these. We used to, even if they had a central line, we have to start an IV. All right. What are some issues you might see with these? Infection. What if they get dislodged, torn out, blocked? Okay. So just know what they are, the different patients that need them and use them. Typically, guys, we see a subclavian So it'll be hanging out like right here on the chest. Sometimes you see it on the IJ, the internal jugular veins up here, but this is a more common spot. You can also see it on the arm as well.
So is it a surgical procedure or do they do it like a?
So it's not a surgical procedure, but it is a sterile procedure. They typically will do them in office, but it's not something that like it takes a while to do because they have to like decon the whole area and all that jazz.
What's the difference in presentation between that and the dialysis?
You're gonna have these two catheter tips, just they're literally gonna be like free hanging out on the outside. Whereas everything for the dialysis is all internal. I believe one is to push medications and you can simultaneously flush it with fluid, or you can give two medications at the same time. All right, tummy tubes, peg tubes, okay? These are for patients who cannot control their upper airway. They run a very high aspiration risk. So instead of giving them any type of diet that they have to ingest through the esophagus, they go ahead and they implant surgically a tube that goes directly into the stomach. They inflate this balloon, it anchors it, it keeps it in place, and then they have a liquid diet that is pumped into that tube. So they're getting the nutrients that they need. Common issues with this?
Anything else that's a tube?
Infection, clogs. Because guys, if this thing gets clogged, you should be able to notice that there's nothing going in, right? But if they're not getting that nutrition, then we can have, malnutrition issues. They're not getting those nutrients that they need. Shunts, there's different kinds of shunts. Typically, what do we need a shunt for? Okay, so there's one about draining some fluid in the brain.
Or
Rerouting. So guys, these channels, these tubes that are important to fluid intake or flow or anything like that, they can become obstructed. They can become like kind of kinked off. All right, so some of these shunts are placed to make sure that this blood flow or the correct flow of this fluid is actually happening. A lot of times if you hear somebody who has a heart attack, all right, if that coronary artery is significantly clogged or affected by that clot, they will actually go in and put shunts in the valves and the arteries of the heart to make sure that it's reinforced, it keeps it open so we don't have that occlusion happen again. Okay. Pretty much the shunts are like reinforcement of making sure that these structures stay sound and they don't collapse or become occluded. Again, depending, especially if it is the brain shunt, if it gets clogged or if it's malfunctioning, altered mental status is going to be a very big presentation. You'll see surgical scars. Hopefully there will be somebody around that patient that can give you that history that this is going on. Typically, if they have something this significant, we want to try and take them to the hospital that they had it placed, right? So they can get the same team of doctors. They'll have all their information there already. So just try to do that as best as possible. Vagus nerve stimulator. What is this? What's your vagus nerve? If we stimulate the vagus nerve, what can happen? Pass out. Right. Fun fact, I didn't say this yesterday, but when mom is pushing, we want to count her down from 10. We only want her to give it hell and give a good push for 10 seconds. Why? Okay, so remember, it's the same muscle action as having a bowel movement. If she is having that pressure for more than 10 seconds, that strong exertion, she can stimulate her vagus nerve and mom can do what during childbirth? Pass out. Not good, right? All right, so the vagus nerve stimulator is a newer treatment in seizure patients. So it will detect, kind of like how the service animals can detect that there's a seizure about to happen. Instead of having the active seizure, this will stimulate the vagus nerve. The patient will pass out and have a syncopal episode versus an active seizure. So it's new and upcoming seizure technology.
Is it born the person that is going to do that?
I would
I mean,
imagine.
right, and it's like,
I would hope you're not.
I gotta sit down and.
Right, let me pull over real quick, or let me put this, set a pot of boiling water down. I don't know.
It's.
Biggest.
All right, so guys, here's your colostomy bags. Depending on where in the intestinal tract it's placed is going to be the title, like what it's called. Okay, so there's an ileostomy or colostomy. They'll bypass. So see here, they're going to bypass and say this part of the intestines is not working correctly, so we're just going to make this the new exit. Okay, this point from here down no longer works. Here's an example of a colostomy bag. All right, they have some pretty sticky attachments that keep the bag onto the stoma, but you can see here it's got, you know, the excrements collecting there. Can be a major source of infection, can just be a major factor if we bust a bag or the patient runs out of bags or something like that. Urostomy is the same exact thing, except instead of collecting fecal matter, it collects urine. So something about the urinary tract is not effectively working. So they'll bypass, instead of it coming out the external urethra, it typically is collected like right here. They call it a suprapubic placement. Guys, some patients that have some of these disabilities or just maybe hospice care, they might have somebody that comes to their home to care for them. We need to rely on them for a report, right? Hey, what's their baseline? How have you noticed them acting today? Blah, blah, blah. But then again, we need to do what? Go back and verify. Take your own set of vitals. Do your own assessment and see if it corroborates. Okay, don't take... Guys, I mean, if you work on the streets and you know these people and you trust these people, like even fire. If fire comes on scene, be like, hey man, I got some vitals for you. Don't be like, hey, thanks, and don't touch your patient the entire time you're transporting them. Go back, get your own vitals. Go back and confirm what these report findings are and that they're accurate and that they've been treated effectively, okay? All right, we talked about hospice and DNR patients. Guys, the homeless population, okay, significant poverty, it's a big thing in Atlanta. All right, socioeconomic status of some of these patients, you're gonna have some culture shock when you go out there. What's true about these patients, especially if they have an illness or an ailment? They might not have access to these resources. They might not have access to, you know, pay for medications, to pay for treatment.
911 might be their only medical care.
Yeah. All right. So again, those loyal Grady customers or those frequent flyers, some of them fall into this category because this is literally the only way they can go see a doctor. All right. And there are like Medicare, Medicaid, you know, Peach Care, all of that stuff out there that helps the financial burden of some of these things, not all of them, and not to the extent that it needs to be. But if they don't have the means to go fill a prescription, who says they have the means to actually like get transport to the doctor's office to do this, to go to the pharmacy? All right. So that can factor into complications that we can see from these medical issues, these disabilities, is just the lack of means and resources to effectively treat it. Questions, comments, concerns? Everybody over here good? Cool. Silence.